Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. You can change your name to your first name only if you would so prefer. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. If you've joined by phone only, note that we may call you after the session to confirm your attendance. We appreciate your support in helping us fully capture this record. Some housekeeping: please stay muted unless you are speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. Or if you prefer, you can use the chat feature to share comments and questions. Please note that no predictive health information is allowed in either the chat or the discussions. During and after the session, the Shout Texas Echo team will send out an evaluation survey link. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. So please go ahead and participate. Our didactic today is on ordering and administering buprenorphine for hospitalized patients. Following that, we will discuss a case presented by Emily Humphrey. We'll start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again for joining today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. With that, we'll do some introductions. Dr. Walker.
Hey, I'm Blair Walker with psychiatry at Dell Medical School and Ascension Seton Hospitals.
Thank you so much for joining us. Dr. Moriartis.
Hey everyone, Chris Moriartis, hospitalist at Dell Seton Medical Center, and I help direct Shout Texas here at Dell Med School at UT Austin.
Thank you. Dr. Lindsay.
Hi everyone, Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring at Be Well, Texas. Thanks.
Thank you so much. Emily Humphrey.
Hi, Emily Humphrey. I'm a family nurse practitioner at Community Care and our MAT clinical lead.
Thank you so much. Andrea Hebler.
Hello, I'm Andrea Hebler, and I'm a project coordinator for ECHO, and I'm here at Be Well, Texas at UT San Antonio. Thank you.
Thank you so much. And now we'll move on to our didactics. Angela at ECHO IT, can you please share the slides? And Dr. Walker, whenever you're ready.
Sure, can everybody see the slides? So we're going to be talking about medical hospital buprenorphine. I've been doing this now since we started the B team, I think in 2018. So we've kind of developed some expertise. We'll be talking as the case proceeds after this about using buprenorphine for pregnant women too. So it all kind of goes together. If you want to change slides, that'd be great. None of us have anything to report, basically. Here's our disclosures. This is a little busy slide, but I literally just sort of spewed out kind of my clinical pearls about using buprenorphine that I've kind of learned over the years. And the most important thing is that it's really easy to use once you get the hang of it. With the caveat, we'll be talking about fentanyl and how that may be a little bit more complicated, but what I always do is ask patients about their previous experience with it. The more they know about it, the easier it is to use. I always engage in patient-centered initiation, i.e., if the patient wants more and they understand how it works, give them more. Let withdrawal be your guide, let pain be your guide. For those of you who don't kind of know what it is, buprenorphine is a high affinity, low potency opioid. There is a precipitated withdrawal risk, but in my experience so far, in the years that I've been using it, it's pretty rare risk. I've actually never precipitated withdrawal in anybody, and I'm fairly aggressive with going for it within hours of last opioid use when patients want to be. It treats pain best with split dosing, so at least kind of 3 times a day. Sometimes we do more often, or we'll have as needed dosing available as well. The general typical daily max for opioid use disorder is somewhere between 24 and 32 milligrams daily. That's the max. I would say, some people will range between 8 and 16 or 8 and 24 in a total daily dose, but you can go higher. And technically there's no max for acute pain. So if I have somebody who's on a whole bunch of buprenorphine and they want to try a little more and it does make a difference, I'm comfortable going more. I also have the luxury of being in a medical hospital kind of doing this. But just something to kind of bear in mind. There's lots of different formulations and they all vary in potency. This is a serotonergic opioid. All opioids are, but this one in particular, and it's the one side effect that I have seen that was like a real concern that's been memorable, that we had induced serotonin syndrome in a higher dose buprenorphine dosing with somebody who had maybe unappreciated, kind of more severe than realized liver dysfunction with Hep C. So just kind of don't forget about that. And then always with pain control in the medical hospitals, multimodal pain management options. So using other non-narcotic, non-opioid agents can make a really huge difference. So I listed off kind of various options. Tylenol, NSAIDs, gabapentin, using more tizanidine and clonidine to help people kind of feel calmer. And tizanidine has some muscle relaxation effects. And don't forget peripheral nerve blocks. And then, of course, I can't help but mention harm reduction. I do a lot of what's it called? When you kind of put habits together, right? And so whenever I'm starting about buprenorphine initiations, I'm always prescribing Narcan like the day that I'm starting everything and sending it to the pharmacy the same day, like as part of my note template to remind myself. You can go to the next slide. I just wanted to show you guys basically what we developed needs some updating, but this is the basically the B team algorithm for initiating buprenorphine. With the caveat that I think that time frame can sometimes be a little more aggressive, and I'm routinely more aggressive. The idea is somebody's, interested in and eligible for buprenorphine, and then you're kind of deciding where they are.
This is Emily. Can you hear me?
Yeah.
Yes.
Can hear you. Did you guys hear that?
Yeah, but I think that was not meant for us.
Okay, got it. So sort of there's 3 lines here, but basically the idea is you're trying to figure out where they are in their risk for precipitated withdrawal. And so, when's their last use is one of the most important questions. Have they had withdrawal before? Are they having any withdrawal symptoms now? And basically kind of follow the algorithm. Most commonly, if someone is already demonstrating withdrawal symptoms with me, I don't even initiate a COWS-based dosing. If a patient is telling me, I'm ready, doc, give it to me, you just give it to them, and it makes it easier on the nurses as well. But for someone who's not yet in withdrawal, who is tolerant to opioids, who does have some opioid theoretically still in their system, the idea would be that you'd wait for them to have at least some withdrawal. It's a fairly low COWS score in the total score, only 8 out of a score that goes up to 40. And then you can usually pretty safely be able to give them some buprenorphine. I always cope ahead with the patients that if we do precipitate withdrawal, the plan would be to give more buprenorphine and aggressively to get the withdrawal away, so that if they get sick with that first dose, they don't refuse the next dose, because you want them to feel better and not leave AMA. But this is sort of the gist of how we do it. The idea being that you kind of get them on as quickly as you can and then stabilize their dose. Once they've tolerated a dose of buprenorphine and they feel better, not worse, essentially for the most part, you don't really need to be paying too much attention to cows, or at least that's what we've seen in the hospital. And by then I get them onto some scheduled, usually split dosing, because most of my patients have pain as well. And then I give them also as needed medication so they can control their dosing. Does anybody have any questions about this initiation protocol as you're looking at it? Feel free to hop in if you do, but it's pretty basic and you'll have availability with this later. If you want to go to the next slide, I wanted to share some slides that are by Elizabeth Salisbury. Dr. Weems, who was going to be our lead with the case next, shared these with me, and I thought they were fantastic slides that she's done. It's basically various different initiation approaches with buprenorphine. So the protocol that you saw just previously aligns essentially with the traditional dosing arm here. So the idea is, you're either doing some traditional dosing or you're doing a cross taper or low dose or even microdose initiation versus a more aggressive rapid start or high dose initiation. And again, in all these cases, I would let the patient's preference and their symptoms be your guide, as well as their theoretical risk for precipitated withdrawal. So the idea being you have various different dosing choices. Is withdrawal required? When to use it? Where has it been studied? And it has some good sample protocols as attachments in this initiation approach options. Next slide. And so just another kind of consideration about the idea of how long your patient might be in the hospital, short length of stay versus long length of stay. When we started B-Team, we were definitely committed to not lengthening stay to keep buy-in for the hospital, to get people onto Suboxone. And I'll tell you, onto buprenorphine, and I'll tell you that we very often can get people over, depending on the case, but for most typical traditional cases can get them over same day if they're willing, as long as they're not on a long-acting opioid. So for instance, have a patient today who's on a PCA Dilaudid and some oxycodone, and if he wants to switch when I see him after this meeting, we'll be able to kind of turn those off and get a CALS-based protocol going, and he may be able to get it even tonight because those are so short acting. Anyone have any questions about anything that I've reviewed? I wanted to make sure that you had access to all these protocol options. Nope.
Dr. Walker, I see
Yep.
a question in the chat.
Oh, thanks.
Yes. Do you automatically do TID if pain is the patient's biggest symptom?
I do at least TID. And, I'll tell you that my favorite protocol is, and it seems like the most common kind of favorite order set that people seem to land on initially after they've kind of tolerated a dose is a 4 milligram. We use the film, so 4/1 3 times a day that's spread waking hours, so morning, afternoon, bedtime, and I let the patient decide what times those are. Some people like to wake up at 6 a.m. and take one. Great. Some people like to wait until midnight to take their bedtime dose, whatever they want. And then I have an additional 3 more strips available essentially any time of the day that they want to take them. And then kind of up or down titrate from there. That's 24 milligrams. And almost every single person I put that on, the next day, they're like, I feel great. Thanks, doc. And it just kind of stays that way the whole time. And often they're not even using all the as needed medications. But it definitely depends on the patient, their, pain tolerance, their receptors, and what the pain's coming from as well. I see Dr. DeMoss with his hand up.
Thanks,
Hey.
Blair.
Yeah.
So excellent overview. I just wanted to maybe ask a question by way of sharing a story. After my first visit to the fabulous Texas Substance Use Symposium last March, I heard Dr. Pappas talk about microdosing and how to do that kind of cross titration that you mentioned, we had a patient on the medical floor who was on high doses of oxycodone with PRN Roxy and some IV Dilaudid, and the primary team, very complicated surgical patient, and the primary team was wanting to get her to a sniff, and so, and obviously in the hospital, surgeons, nothing against surgeons, but they want it yesterday. And so, but they were willing. We got enough buy-in to avoid the having to go through withdrawal by cutting off all the full agonist opioids, and they were willing to allow us to do some microdosing over time with this patient. And we just have the sublingual tablets, the monoproduct tablets, and our first kind of foray into the microdosing world was with this patient, and we had great outcome. In just 6 days, we were able to get this person off of all the full opioid agonists and get this person to the sniff in 6 days. It was very remarkable.
That's awesome.
Yeah, and so the question, I guess, has anybody, you or anybody in the audience, experienced any pushback from primary teams on when it's appropriate to do microdosing in the hospital?
Sure. I'll go for sure. Time is of the essence. I work primarily in the level 1 trauma hospital. So, and we're always full to the hilt with people, in virtual beds, as we call them, in the ER, as they're waiting to get a real bed upstairs. So there is, but I would say the culture has been shifting to recognize that we've got to play the long game with people. I will say we also, this isn't really focused on methadone use, but we also use a fair bit of methadone as well for people who are admitted to the hospital. And we have some workarounds, the luxury workarounds, because we have a big hospital system of small community hospitals that are our sister hospitals. We can send people to a swing bed, is what we call it, instead of a sniff, where they can dose the methadone out of their Omnicell or Pyxis, their medication, their inpatient pharmacy. And so we have some little workarounds, or and we have a nonprofit hospitals willing to pay for an LTAC sometimes when people have no funding. So we have a little bit of added luxury with a methadone addition option, but I always remind folks who aren't seeing the big picture that if we don't get them help now, you will see them again sooner rather than later with a similar issue. They're here for terrible abscesses or whatever it is. If we don't help them change all of it, then we're just, slapping a Band-Aid on the problem and they'll be back. So, or God forbid worse. So I think that we all have the ability to advocate for kind of changing that attitude, but it's hard. You and I are consultants. We are not the boss of when people get discharged. So, and I think it also really depends on the patient. I think there are some patients, I've had a lot of patients say, no, switch me. Just stop it all. I'm ready. I don't care. I'll be fine. And if a patient tells you do it, let them do it. Don't be afraid to just turn off all the other opioids and give them a bit of time and then aggressively dose the Suboxone. I've had a lot of success with that in patients who are more than, they have to be really ready for that and not afraid of it. But I think you'd be surprised how often people really are great, I could get out of here in 2 days on Suboxone and you'll get me set up. Great. And they really kind of go for it, and they do feel better on the other side. Does anyone have any other questions? I think that's the end of our slide set, Angela. Just making sure as we went sideways. Oh, okay. Wanted to talk about special considerations. So we've already talked about this, and there's my favorite kind of acute pain regimen. And then I kind of up or down titrate. I mentioned Hep-C and just being cautious with acute severe hepatitis or transaminitis. I certainly have had a percentage of patients who are completely almost obtunded on a 4 milligram Suboxone, which was sort of shocking, but I definitely start lower with liver failure concerns. And again, I sort of mentioned it already, but coping ahead with precipitated withdrawal. The other thing I wanted to mention, which isn't necessarily the focus of this, but just realizing that plenty of people come in who are going to concurrently be at risk for GABAergic withdrawal, like alcohol or benzos. And my general philosophy is, if they're having a mixed withdrawal syndrome, quickly get them onto buprenorphine in a stabilized dose aggressively so that you can focus on the GABAergic withdrawal, which is going to be more dangerous, associated with strokes and seizures, heart attacks. So the CWA scoring or alcohol withdrawal scale scoring isn't going to be as accurate. So I would also keep in mind that you could overuse or over administer benzodiazepines to folks who are going to have a mixed withdrawal syndrome. Again, why I get them on something to stabilize the opioid withdrawal quickly that's not just symptom based, so that we can focus on the other. And then I use a lot of non-benzo augmenters for all people who are going through alcohol or benzodiazepine withdrawal. So clonidine or Precedex, if you have that availability. Gabapentin, Depakote is another option that can take the place of gabapentin. If you use alpha agents like clonidine and Precedex plus GABA or Depakote, which are both GABAergic and can cover some seizure coverage, it really does minimize the amount of benzos that you need to use and risk for delirium if it's coming from the medicine rather than the GABA withdrawal. So just wanted to kind of float that out there. I think that's the rest of our slides. Next slide. Yeah. So any other questions about this? And if not, then we can move on to the case.
Dr. Walker, there was a question from
Sure.
Megan. Megan, did you want to unmute and?
Oh, I see. What do you do with admitted patients who are started on Suboxone and then have the surgery team discontinue it? Is there a legit surgical reason to discontinue Suboxone? I don't think there is. The general recommendation and kind of standard recommendation is to stay on some Suboxone if you have opioid use disorder. I think with really complicated pain, there could be an argument, and it's a little kind of clinically, it may or may not be indicated, but there is an argument to kind of decrease the dose if you're struggling with other opioids augmenting on top for pain. Like maybe you've tried to max out the buprenorphine and it's really just not enough. They have broken femurs or something terrible. Or I have a lot of burns patients here. So, again, I think having discussions with the surgery team, coping ahead, keeping some on. We early on with B team talked a lot with anesthesia and surgery about this. What we've seen is that we don't touch the dosing for the most part, and people do beautifully. So I've had plenty of people who are, here for a massive abscess, need to go back to the OR a number of times for terrible wound care that they can't tolerate at bedside yet. And the anesthesiologists use not that different dosing of often propofol and fentanyl are the most often medications we use here for intubation, and sometimes some fluorine anesthetics under anesthesia, but they do fine. And it doesn't seem to be really an issue with induction and getting them intubated. So I think sort of preparing for that, reaching out to your anesthesiologists and talking with the surgeons about that to try to help them get more comfortable with it. Yeah, that's my main answer. But ultimately, I will say ultimately as the consultant, if they turn it off, they turn it off. If they're absolutely adamant that someone shouldn't be on it, you can always get them back on it later. But I usually say, well, let's split the difference. Let's put them on just the tiniest dose we have once a day. We won't even do it 3 times a day. And we'll just leave that one little dose on there and we can still give them whatever else you want to give them. And usually you can talk them into it.
That's interesting. Good to know. Yeah, we had someone admitted for an abscess and then I checked in a few days later and all of a sudden surgery put them on methadone. It's like, why?
Yeah.
Why did you do that?
What's happened at our hospital is that they call our B team for everything because they're like, great, B team will deal with the pain control. And they just sort of check out on that and don't do any other opioids and they love it. And actually, most of our patients with abscesses, you can manage pain with just Suboxone. That's what I have found. And they do really well, even really giant ones. Anyway, so yeah, it happens. Any other questions? And okay, additional pain control with short-acting narcotics on top of Suboxone. Yes, you still can. And I'll tell you, I try not to dose them frequently as needed on top of buprenorphine. I try to use extra buprenorphine where at all possible. The way that I usually, and again, depending on the level of pain and pain source, but the way that we most often try to do it with the patient is lots of multimodal agents, sometimes benzos too, if they need something else, picking a benzo that is longer acting, sometimes that like low dose Valium that also has some muscle relaxation effects. But the most often time that I'm adding opioids is for wound care. So a decent dose of something for wound care once a day max is sort of my preferred addition. I try not to use opioids just for pain if they're on buprenorphine, because I'm sort of trying to take them away from the popping pill kind of habit. I'm a psychiatrist, so I can't help it. Try to get things sort of stabilized, but we do often use either oral or IV Dilaudid, and we're more aggressive with the dose. That's the other thing. If I have somebody on decent doses of buprenorphine, a milligram of IV Dilaudid is kind of at least, and people do well with that and don't seem to get super sedated or super euphoric or anything, or maybe 4 milligrams of oral Dilaudid if their pain isn't that bad with wound care. But you can break through to some extent. All of the opioids can compete to some extent.
Thank you so much, Dr. Walker. This was a wonderful presentation and a equally wonderful discussion. I see one of our hub members has joined the call. Dr. Ramesh, would you like to please unmute and introduce yourself?
Hi, everyone. I'm Jan Ramesh. I'm one of the hospitalists over at Del Seaton. Sorry for joining late. I was having some technical difficulties.
Thank you so much for joining us. So now we'll move on to some announcements. Echo IT, could you please share those slides? Thank you so much. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide. The Be Well Texas Clinic offers high-quality treatment for addiction recovery at low, no-pay or self-pay insurance, so all patients are accepted regardless of their payment ability. Next slide. We have two new ECHO programs coming up soon. The Public Safety ECHO for public safety professionals and first responders, and the SUD ECHO for behavioral health directed at behavioral specialists. Do watch out for our emails. Next slide. Shout Texas is thrilled to announce the release of its comprehensive toolkit for hospital opioid use disorder treatment. The 50-page toolkit contains sections on the clinical application of buprenorphine in the hospital setting, how to develop your own hospital-based treatment program, and overviews of the mood, regulatory, and reimbursement landscape in Texas. This toolkit is free and available on the Shout website. You can see the link in the chat. Next slide. Our next Shout Echo is on Thursday, July 21st. We have some exciting speakers, so please do join us. Next slide. Please join us on Monday, June 27th for a 10-minute Get Waiver training directed to emergency personnel and first responders interested in prescribing buprenorphine to patients with opioid use disorders. And thank you. So now we'll move on to the case. Emily, once Echo IT has the case ready to go, you can start off.
Awesome, thank you.
Thank you.
My name is Emily Humphrey. As I mentioned earlier, I'm a nurse practitioner here in Austin, Texas. I work at community care in our outpatient MAT program. So all of this will be outpatient, this case. And I have been doing addiction medicine in some form or another for about 9 years. to give y'all a little context. So for a couple of years, I was up in Nashville at an inpatient facility for women where we did all substances and we took pregnant women. So I have decent experience with pregnant women and opioid use disorder, but this case was an interesting one for me. So my questions that I want to introduce first to be thinking about as we go through this is for pregnant patients who are physically dependent on fentanyl. So specifically fentanyl, what approaches have you found successful for initiating buprenorphine? Dr. DeMoss, I found it interesting you brought up microdosing or low dosing, because that's what I'll touch on some today. Have y'all found that successful or other methods? And then my second question, are other buprenorphine prescribers requiring that pregnant patients who are physically dependent on the fentanyl initiate buprenorphine at an inpatient detox facility with monitoring? Or are some of you also doing this in the outpatient setting? And if so, where are all of you out there? So those are my two questions. So if you want to scroll down. So as I mentioned, this patient is not being admitted. She was outpatient, but I did include a brief little thing at the beginning to get us started in that section. Initiating buprenorphine in those that are physically dependent on fentanyl, we have found is more challenging just because fentanyl is more lipophilic and so it sticks around longer. And so for those non-pregnant patients, we're just finding it usually takes a couple weeks for them to feel really good. And that's just anecdotal that we've been seeing in the clinic. For our pregnant patients, that makes it a little bit more complicated when we are trying to keep withdrawal symptoms at a minimum just to decrease the risk of miscarriage. So due to the rising presence of fentanyl in our community, this is going to be something, unfortunately, I believe we're going to encounter more often. We have more pregnant patients in our program right now than I've ever had in my 5 years here. So for this patient specifically, she is an 18-year-old female. She began snorting fentanyl about a year ago. She denies all other substance use. She is currently 17 weeks pregnant. Approximately 6 weeks ago, she went to an inpatient treatment facility and was started on buprenorphine. And then she left AMA, tapered herself off due to concerns about the baby, and then quickly returned to use of fentanyl. So then I was actually at a conference in Seattle and received a call from one of our community health paramedics, one of the PAs with that team, who came across this patient on the street, and she was wanting to get back on buprenorphine. And he was asking what I recommended. And at the conference, I literally just came out of a seminar on microdosing for patients using fentanyl. So it was really fortuitous that this all lined up. And so like, well, let's try microdosing or low dosing approach. And so he started her on 1 to 2 milligrams as tolerated of buprenorphine and told her if she needed to, she can continue the fentanyl and have her follow up with us. So she followed up with us 5 days later, and she'd been taking buprenorphine 2 milligrams in the mornings and then chipping with fentanyl in the afternoons. At that point, we increased her dose to 4 milligrams 1 to 2 times a day as tolerated. Followed up with her 6 days later. And at that point, she was doing really well. She was up to 4 milligrams twice a day, and she had not used any fentanyl in a week. So go ahead and scroll down. She denied any withdrawal symptoms, any cravings, and she had gotten established with OB. So really successful and really exciting that it went so well. As far as past medical history, she's been treated multiple times for STDs in the past, and lots of interpartner violence was documented in the chart. Only meds were prenatals, no other medications or medical issues. As far as her social history, she had been on the street some. She was living with her mother by the time she got to us, her teenage brother and her infant brother, who all three often come to the appointments. She says she has good support from her mom and grandmother. She doesn't have a car, but they drive her around. Her working history is interesting. At times she said she's working 40 hours a week, and then other times she says she's unemployed. So we're a little confused. And the father of the baby is currently incarcerated. You want to go down a little bit more. She denies any psychiatric history. However, she is very withdrawn during her visits and is not giving us much information. So I suspect there is more there than she is reporting. Additional comments are just her mother mentioned to one of the counselors in passing a few weeks ago, hey, sex trafficking is involved here. but she hasn't given us any more information. And so we're trying to figure out that part of the history as well. So we're still uncovering some layers to this particular case. No other substance use reported besides the fentanyl and some THC. And so that is our case. So going back up to my original questions, now that you've heard the case, this case, as far as just getting her on the buprenorphine, was fairly easy. We anticipated it being more challenging, and it did go very smooth to do the microdosing approach. But I was curious what other people have found to be successful for pregnant patients on fentanyl, dependent on fentanyl. If you ever try the high dosing approach with fetal monitoring, or if you're doing this in the inpatient setting and so on, what have y'all found successful?
Thank you so much, Emily. Yes, Dr. Walker.
Thank you. So I would just open the floor. What do people, anyone have any thoughts? I see James Bridges has hand up.
I will say too, I have 2 more scheduled on my panel for next week. Same scenario. So I would love your help.
It sounds like your case you were telling me was a success, that she did really well with it.
I'm 1 for 1, but
Nice.
I don't know if this is going to continue.
So what are people's thoughts about this and their experiences with pregnant women and with rising use of fentanyl? Anyone seeing more difficult initiations? I see Gail with her hand up. So, I mean, for me, looking at the case, I mean, just in general, we always sort of stop and pause with pregnant women. Even now, especially with this sort of darkness surrounding what might happen with prosecutions if someone should miscarriage, for instance, I tend to stop and just reframe, pregnant patients you're always balancing risks. That, yes, it's a risk benefit, but it's really risk versus risk. So what's the risk of starting this lady on low dose versus high dose? If it's low dose, but she's continuing to use fentanyl on the streets, she's on the streets, she's, she's still kind of in that environment that's much higher risk for being attacked, something else happening that has maybe kind of a side concern. And so, I mean, I think, getting a bad batch and overdosing in the meantime while you're working on it. So we're always weighing that risk. I think some of the things that I have learned over the last few years with OB patients is that it sounds like this was successful. I would always, again, let the patient be your guide. What do they need? What do they want? I think that our area OBs, if say someone said, I want to do this, but I want to get aggressive with it and be in a more contained environment, there could be a case for someone who's less stable or further along in their pregnancy where they might be at higher risk for early labor. Or maybe earlier in their pregnancy, higher risk for miscarriage. My understanding is the second trimester is thought to be the safest time. So she was actually like in the perfect time frame to kind of slide this in. And also, I think she's been living with her mom. Was that after she got on Suboxone or during the time that you were initiating?
Yeah, it was, so when the community health paramedic found her, she was outside on the street.
Okay. Yeah.
By the time she saw me, finally 2 weeks later, she was back in with mom.
Yeah. And I would again always be very patient-centered, and what does that person want and what will help them stay retained in being engaged? She sounds like she was really motivated and wanting to do it. Some of the things that I actually asked Dr. Weems, since I think he does a lot more of this in the community with you. He sort of passed on some of his pearls. And I think with fentanyl, the idea is because it's so lipophilic, it builds up in your fat, apparently the powder form in particular, so she's snorting it. Powder form in particular is like the worst form to kind of develop this erratic, basically release of the fentanyl over time that's built up in your adipose tissue. Emily, you were telling me that you've been seeing people in the community that have like weeks of just kind of vague withdrawal symptoms on their buprenorphine ongoing,
Exactly.
and it's just nasty.
Yeah. And
Um,
it took us a while to make that connection. Like, these are our fentanyl patients.
yeah.
But yeah, it seems a lot longer. Eventually we get there, but we just have to warn them this might take a little bit longer to do more supportive care.
Yeah. And so, yeah, hand.
Hi, I'm Emily, another Emily. I'm Emily Ibarra. I work with pregnant women with substance use disorder at Ben's Hub. And I'm so sorry. I think I was talking and interrupted you, Dr. Walker, during your
Oh,
call,
not at
'cause
all. No, it's a discussion. I want
I
people
had-
to talk. I'm filling the
I
hole.
just got a call from a woman who's 7 months pregnant and snorting heroin with fentanyl. And we have seen, so it's interesting. We get women saying that they're taking heroin. I'm getting so many texts from pregnant women who are trying to go to the hospital, and people are like, they're like, they get passed off, and I get so frustrated, and this is what's happening to my patient right now. So sorry, but yes, we get this. And the other thing that's interesting, and I work in a county setting, so we don't have as many resources, like even with our lab testing. So the other thing we're seeing is people are telling us they're using heroin, and the opioids is not testing positive because we don't test everyone for fentanyl because it costs a lot of money. And also not even every physician can order it, which is very interesting. Only our addiction medicine psychiatrist can, and he doesn't work the OB floor. So that's just one part. And so we'll see this where a patient is feeling really shitty, and we know it. They might have taken fentanyl, not known it, which is comes around a lot. But with these patients, we're just having to go really, really slow. And it's frustrating for all involved, but we explain and I actually have never, and I can't wait to share what you said, Emily Humphrey, about the chipping concept and things, and I'll share that with our addiction medicine psychiatrist. But I think the huge part, and it's a very real part of when we start this treatment, is that we have to see where the patient is. Are they really wanting to stop? And if they're not, let's talk about harm reduction and all of that stuff. But if they're not, maybe it's not the best time. And I hate, it sounds really kind of almost unethical to say that, but again, just last week, we had a patient come. She's been somewhat engaged, not really interested in coming back to clinic. We started on Suboxone. She doesn't want to participate in outpatient groups or anything, which again, it's her decision. But she showed back up using oxycodone pills and missed her appointments for her refills for Suboxone. So we're like, look, we have to admit you to do this safely again. And she left early. She didn't want to stay. And so it's this push and pull. And I know this is not the science part, but it's obviously very real to the picture. It's just the push and pull of having very real conversations with the patient is this is what it's going to take to keep you on this track in recovery and your medicines. Are you ready for this or not? And we're here for you when you're ready. And that's the other thing. We are very accessible. I give my patients my cell phones. I don't advertise that to everyone because I know the hospital doesn't like that I do that, but they need us when they need us, and it's not, and that's all we can do. And so again, non-popular opinion, but just sharing that. So thank you.
Thank you. That was great.
Thank you, Emily. I see a question in the chat here. In the case presentation, were you using BID dosing of buprenorphine due to the higher metabolism rates in pregnancy?
I was doing BID dosing, but not necessarily due to the higher metabolism. I find that we often do BID dosing. It just helps the patient feel a bit more in control for whatever reason. And for her, we were just trying to give her options depending on withdrawal symptoms and how she was feeling. And it worked. And so we didn't mess with it. But if she had done once daily dosing, that was okay too. Yeah, we were just leaving it up to her once or twice daily.
I love that you bring that up. I think that the idea of, again, putting patients in as much control as possible. They know their bodies, they know how they're feeling. They're going to dose the buprenorphine how they want because you're giving them a prescription of it anyway. So why not set it up in the right patient who seems like they can manage it for them to decide this is what you have in a day. If you need a little more, there's a little extra. You can, I mean, I routinely am prescribing that way. And I wonder if with these patients where you're microdosing, if you have extra just in case, because if they feel like they're in withdrawal, you want to make sure they have enough to try to get rid of it. And I wonder if you'll see success in that way. And there may be some cases where they do need a lot more than you think they do. I also wonder about those patients who are feeling kind of gross for weeks. Do they just need more Suboxone when they need it as it's leaching out of their adipose tissue to sort of account for that? I don't know. I think time will tell. I think we'll all kind of gain more kind of comfort level and experience with it over time. Anyone else have any other thoughts? Some more information that Dr. Weems had sent that I thought was just really interesting about and good to think about with fentanyl in particular. What he passed on was that what he's seeing is definitely more of the fentanyl issues, predominantly overdoses, also more tolerance with really quick onset. So like developing a habit in less than a week after starting fentanyl. One thing I would also tell you is that we're seeing Xanax pressed fentanyl tablets. You know, basically, if they tell you they think they're using fentanyl, they probably are. It's what I would say, regardless of a lab test, because it's really out there these days. And the other things that he's noticing are like higher buprenorphine doses required to stabilize, more severe withdrawal earlier into the abstinence timeframe, and in increasing tempos of like complicated bup starts in patients using the powder fentanyl. What he said that's been most striking is that he sees precipitated withdrawal 18-24 hours even into withdrawal, even with really high CAL scores where you think you're totally safe to give them a buprenorphine dose. And again, I think that's where having, you know, kind of having people have extra buprenorphine just in case, I think I think I would do in the right patient. He says that you guys have advised people to wait longer, maxed out comfort meds, sometimes benzos even in some cases, and that often they're starting with higher bup doses. And again, these are non-pregnant patients, and then have done some low dose microdose starts. And thinking about the chief indications for this, like people in particular who have really strong reservations about precipitated withdrawal or ambivalence about starting kind of meds for OUD anyway, who can't tolerate any withdrawal whatsoever. And you just have to really organize, have a pill box, lots of visits and lots of support. And all of this, of course, is much easier to do when you're inpatient and have them right there where you have a nurse sort of watching them and dosing them as much as they need. So it's really hard in the outpatient side. It sounds like your case was absolutely a success. And I think, you know, how do you navigate? Pregnant women it's always a little bit more complicated because you're dealing with two lives. You're dealing with the pressures of the pregnancy and supporting that woman through it. But I think always remember risk versus risk. It's always risk exposure that you're weighing. And you know, I'm curious if anyone else is seeing pregnant women. I happily, the trauma hospital actually doesn't typically have pregnant women admitted here, but I've certainly spent some time at our sister hospital and I have a colleague over there. We do occasionally have women over there. I think that this has become a forefront issue for the obstetricians. I know that if I had someone come through the ER and and the OBs came to see them as a consult and they thought they might be unstable, they would admit them over to the L&D like antepartum unit, and when we'd work with them on it. But not everybody has that luxury. Again, fetal monitoring, higher dose, I think ultimately also letting the patient themselves decide kind of what they want, and then you deciding on your comfort level without being, obviously too cavalier. And basing it based on trimester too, and history of miscarriages before, and that sort of thing. Does anybody have, what's a really good case? Anyone have any other thoughts? Emily, do you feel like we've kind of hit some of your questions?
Yeah, I think the other question I'd have would be Austin specific. Just if I do have a woman that is more comfortable doing this on an inpatient side and it's only opioid use disorder, I can get people in fairly quickly for benzo or alcohol use disorder in pregnancy, but if it's just opioid, that's really challenging. And so I didn't know who else is doing this in the community on the inpatient side for pregnant women for opioid specific.
I'm not aware.
Because I just keep doing it on the outpatient side. So I would love to know who's on the inpatient side.
Yeah, and I mean in Austin specific too, for folks who are unfunded.
Right,
They
and that's
might
most of my patients.
They might make an exception for detox because the woman is pregnant. They do not fund detox at our detox facility for everyone else.
I found
it's
most
just
of
that.
the people I've attempted are just, I say pregnant and everyone's scared.
Yeah, Shoal Creek does it. And I'd say that they don't do fetal monitoring. Again, it's sort of risk versus risk. If you have nothing else, you sort of have to weigh the availability.
There's no one else but us in the Houston area, and y'all know a bigger medical center that does this, what we're doing. Even Texas Children's, which is big and fancy, they have their women's pavilion. They don't start women and admit them on antepartum, but that's the best way to do it, is they need to be admitted on antepartum.
I will say we've had some rumblings recently of some pregnant teenagers in the Austin area and how we're navigating their psychiatric needs in general. And so I think it's probably going to be improving fairly soon, I hope, from just all pregnant women in general in the Austin area. But
Dr.
it's
DeMoss has his hand up.
Yes. How's it up in Fort Worth?
It's tricky, like everywhere else, but we have the luxury, I guess, of being the level 1 trauma center, but also have a pretty large OB residency. And so our OB colleagues are always asking for help in the OUD pregnant population. And fortunately and unfortunately, we have great opportunity for education in that department, and we've rolled out a lot of our education over there because they're doing a lot of methadone inductions for pregnant women, which is fine. But a lot of these folks, as you know, they're top of the wait list, but they're on a wait list for some of the clinics out here. And so we've done some microdosing in that population with good success. One thing, and this is probably, we definitely don't have time to hit the topic, but one area that we've struggled with is the justice involved pregnant population. The only time I can get OUD treatment for anybody in our jail is if they are with a fetus. Otherwise, we no luck whatsoever. Until like last week, we got a letter saying, hey, according to the Americans with Disabilities Act, you are now supposed to be doing this. And so I'm anxiously awaiting our opportunity to start treating over there.
Well, you can tell them that Travis County does it for everyone.
It's a major thing, but there's so much that falls through the cracks there too. And there's a lot of misinformation in correctional health about the safety of like methadone, because we can't even, they don't even allow buprenorphine in the jail for pregnant women. They will not give it to them. So they're literally taking these women in Harris County every morning to the methadone clinic, which, let's talk about a waste of funds. And then if they miss their ride because of the operations of the correctional health system, they come to the hospital. for their dose. And so we literally just had a call yesterday with the Harris County jail folks about the pregnant women. And then also their question was, when they're postpartum, how long until we can stop the methadone? And so they really think that methadone is like, and they'll say they need a detox from methadone is kind of like the language they use. And so, but we do use methadone here too. And that was actually another question I was going to ask you, Emily. It was like, did y'all consider methadone for this?
We don't do methadone at this site.
Oh, because you're outpatient. Yeah.
Outpatient.
Yeah.
Yep.
But I will say, Emily and I were talking about that, and I do wonder about a patient who has it available. It might be easier to get them onto methadone before you eventually switch them to buprenorphine and just get away from the fentanyl weeks later.
But you have to be very careful about that transition,
right?
If at all. And so,
and what we do know is that buprenorphine has a lower incidence of neonatal withdrawal syndrome compared to methadone, and maybe the combo products are better than straight buprenorphine even for that, is what I was just reading in an article that Dr. Weems just shared with me. But I think either one is better than using street opioids. So
100%.
again, you kind of do what you can do with each patient. I will say in Austin, we've had success over the years in getting pregnant women straight into the methadone clinics. It's the only incidence where we have someone in the hospital, for instance, who prefers to be on methadone rather than buprenorphine. They've done it before, been successful, and we can call the clinic and they get them right in, which is like the one time that we can do that, which is always appreciated, but it's tricky. What other thoughts do folks have?
I see a question here on the chat. Is there any particular guidance you would give patients in preparation for the neonatal abstinence syndrome if the mother is on buprenorphine?
Yeah, we have that conversation with all of our pregnant women in the program a lot throughout their whole pregnancy. And so, you know, we adjust the dose of bupe throughout pregnancy, depending on metabolism and side effects, constipation, right? Because of pregnancy and bupe. And so we really try the lowest effective dose. And, you know, I've read quite a bit of different literature regarding NAS and bupe dosages, and there does not seem to be a correlation, which doesn't necessarily make sense, right? You'd think the higher the bupe dose, the more likely to have NAS. And that's not the case. We think, or, you know, they think that there is probably some genetic predisposition into how the placenta is filtering this that might be affecting that. And so we really don't know. And so, you know, I always tell the mom, we want to make sure that you're not in withdrawal, that you're not having cravings, and do that at the lowest dose. And then the NAS, I educate as I would for anything else, you know, lots of skin to skin, breastfeeding is recommended, continue taking your bupe. Some bupe is secreted in the breast milk, although very little, but that might help with some of the withdrawals that the baby's experiencing because you're still getting a little bit of the buprenorphine. And I would say that with all of my pregnant patients, it's about 50-50. About 50% of them, their babies do have NAS and end up in the NICU for a little bit, and about 50% have none. And it's been pretty consistent with the literature I've read. There's no predicting which ones. So we just warn them about that and have them very prepared mentally to take that on if that's the case. I also write a letter for each of my pregnant patients to take with them when they go into labor, just in case it's with someone that's not as familiar. And I have my personal cell phone on there, and I tell them we do recommend continuing breastfeeding while taking the bupe. We talk about pain control if they have a C-section, to continue the bupe during that. I encourage them to increase the bupe if they have postpartum pain rather than trying other things. So I have a standard letter that I give to all my pregnant patients and have them give it right when they get to the hospital. So
Awesome. That's great.
This has been an amazing conversation. Dr. Walker, could you please summarize the recommendations? I know this is a challenging task.
I can try. So what basically the things that we reviewed were that we're going to see a lot more fentanyl. We're already seeing a lot more fentanyl. It's lipophilic, and so it gets a little complicated with buprenorphine inductions, initiations, and it leaching out of the adipose tissue over time. In pregnant women, second trimester seems to be the safest for risk for miscarriage or early delivery or early labor, I guess I would say. But you're risking, they're always going to be at risk for this, for lots of different reasons as well. If you can monitor on an inpatient or antepartum unit, that would be ideal, but you kind of work with what you've got in your system and in the moment. Emily talked about micro dosing with buprenorphine for folks on fentanyl, and especially given the miscarriage risk in pregnant women. And we also talked about maybe having extra as needed dosing and let patients have some control over their dosing, since they're almost always in kind of outpatient status. Those are kind of, I think, sort of the main big topics, and maybe just floating another plug for advocating and continuing to fight the good fight with with the justice system and our surgeons and OBs and everybody, keeping everybody as well educated as we possibly can. I think that about sums it up. Any other questions or thoughts as we're coming up on time?
Well, thank you so much, Dr. Walker. Thank you all for joining today's ECHO session. As a reminder to earn CME and CNE credits, please complete the post-session survey using the link in the chat. We do look forward to seeing you at our next session, which is on Thursday, July 21st. Have a wonderful rest of your day. Thank you.